My name is Professor Dr. Pauline Lai, and I'm from the Department of Primary Care Medicine. It gives me great pleasure to actually introduce to you our next speaker, Dr. Liong Fuang, com more commonly known as Dr. Alice to all of us. She is she is very passionate about her research topic, which is about advanced care planning. She also belongs to the Special Interest Group for Advanced Care Planning Research in University Malaya. And the topic of her presentation is, what are the views of older adults with HIV on advanced care planning? Over to you, Dr. Alice.
Good morning, everyone. Thank you, Prof. Pauline, for the kind introduction. Very good morning to everybody. Today, I'm going to present on what are the views of older adults living with HIV regarding advanced care planning. As we know that the numbers of older adults living with HIV are actually increasing. In Malaysia alone, the population was 2.9% 10 years ago in 2014 and has increased to 8% in 2023, according to the most recent Global AIDS report published last year in 2024. So what would be the impact when there is getting more numbers of older adults living with HIV? First of all, the care for older adults with HIV is complex because of aging-related comorbidities on top of their current condition. Secondly, the mortality rate of HIV population compared to non-HIV population is still higher despite the use of antiretroviral therapy. And besides that, studies also shown that HIV population are actually developing comorbidities at an earlier age compared to non-HIV population. Secondly, in terms of social challenges, people living with HIV are faced with social isolation, as well as they have a limited circle of confidentiality, because sharing their condition is can be difficult for a person, especially when there is a HIV-related stigma. So other than HIV-related stigma, there is also ageism as a person grow older when they reach the age of more than 60. Okay, next. What is advanced care planning? Advanced care planning is actually continuous discussion. It's not only a single discussion. It's a discussion that goes continuously, multiple sessions between the healthcare providers. It can be a doctor, it can be a ACP facilitator as well. Somebody who has been trained to discuss on advanced care planning, ACP in short. So this discussion is between the patient and also with their loved ones. So the loved ones can be their friends or family members, someone whom the person trusts. The discussion will be revolving around a person's values and goals and their preferences, as well as their current state of health. What is the current disease, the trajectory of the disease, as in how the disease progresses. And of course, in advanced care planning, we will also discuss regarding the future care, what is their preferences for their future care, and also the care for the current condition, current illness up to the end of life care. And finally, there will be discussion regarding death as well, such as their preferred place of death. And however, a recent study, which is published by our team, also our moderator, Prof. Pauline, one of the author, 3% of Malaysian adults have heard of ACP. So it's a very limited awareness in our population. Only 3% have heard of it. However, more than 80% are actually interested to know more about ACP because they feel that ACP is important to them after we explain what is ACP to the community adults. So in terms of people living with HIV, a recent guideline published by the British HIV Association recommend that clinicians to discuss ACP with individuals living with HIV as a part of a holistic care, comprehensive care to people living with HIV. So, our country also moving forward as we are advocating for ACP as well with the recent publish of the Advanced Care Planning Guideline. So in this guideline, which was just published last year, 2024, it mentioned that who can have ACP? Any adults at any age, at any stage of health, even a healthy adult can have an ACP discussion. Focus are particularly bring on to individuals who have a chronic life-limiting illness, whom should be prioritized to have an ACP discussion with their healthcare provider. Besides that, our Ministry of Health actually developed a website for advanced care planning, which is dedicated for public caregivers as well as healthcare provider. So in this website, there's a video as well as introduction to advanced care planning, how to go about it, and the guidelines for healthcare providers are also included in this website. So the focus of today's sharing is about my master's thesis, which is on the perspectives of older people living with HIV on advanced care planning. So this study has been published this year recently, and the other author of my team is Professor Nick Sherina as well as Dr. Ng Wei Lek. The objective of this study is to find out, to explore the perspective of older people living with HIV regarding ACP. So how did we conduct this study? It's a qualitative study in which we conduct in-depth interview one-to-one with people living with HIV from March to May 2023. It was done in 2 primary care clinics. It's a government clinic, Klinik Kesihatan in Kuala Lumpur. So the participants that we selected were people living with HIV who attend the Klinik Kesihatan and age 50 years and above. So many of you will be wondering, why 50 years old? Well, according to the United States Centers for Disease Control and Prevention, CDC, they define older adults with HIV as 50 years old and above because this age limit is significantly higher than the mean age of the HIV population. So next, the interview was conducted based on a structured, semi-structured interview. We used the theory of planned behavior to guide our interview. So this theory of planned behavior, there are 3 factors that can influence how an individual intend to engage in ACP or not. First of all is the attitude. What do they think of ACP? Whether the attitudes towards ACP discussion is positive or negative will affect their intention to complete a ACP documentation or to proceed to ACP discussion. Secondly, how do they view the people surrounding them? For example, their family, friends. Do they support the person, the individual, to engage in ACP with a healthcare provider? And thirdly, how much self-control, how much control they perceive that they can engage in ACP, whether it's a complex procedure or something very simple that they have in control with, they are able to attend the session or not. So these are the 3 factors that guide our interview. Sharing here the results of our study, we actually have 17 participants. So by the time we reach 15 participants, actually the data are saturated already. So we have conducted an extra 2 interviews to ensure that we have reached data saturation. Looking at the demographic, our participants range from 50 to the oldest, 75 years old. And some of them are newly diagnosed with HIV from 2 years up to having HIV for 33 years. Our participants are male, female, as well as transgender, consists of ethnicity of Malay, Chinese, and Indian. In terms of religion, There are Islam, Buddhist, Hindu, and some is atheist as well. Most of them are single, a few are divorced, widowed, and one is married. So in terms of comorbidities, majority of them have comorbidities. So when we ask them about ACP, actually many participants agreed that ACP is important to them, despite hearing ACP for the first time ever during the interview. Okay, so I quote from this participant number 16, who is a 51-year-old man. So he has HIV for 21 years, together also have a hepatitis C. So when asked about have he heard of ACP, he said, all this while, I do not know about ACP. I heard about this from what doctor said to me just now, but I'm interested after hearing this because I have chronic illness now. So chronic illness means to him is the HIV. I think I need it. So ACP is something that is viewed as important to most of the participants who live with HIV. So what do we found? Actually, we found 4 themes. The first theme is the normalization of HIV. Now HIV is being normalized as a chronic illness. And because of this normalization, it actually leads to the view that SCP is not so needed at this stage. Secondly, the views on death. Actually, many participants have different views on death, and it actually results in a different attitudes towards SCP depend on their views on death. So we can see that the views on death is something that is important here, which have to be included in SCP discussion. Thirdly, the fear of HIV disclosure. So HIV-related stigma is still very prevalent here, and the fear of disclosing this status actually can affect the uptake of SCP. And finally, many express a desire to have a SCP that is dedicated, which a service that is dedicated. So what do I mean with this? I'll further explain each of these themes in the next few slides together with the quotes. Okay, for the first theme, normalization of HIV negates the need for ACP. So let's look at the first this participant, who is a 60-year-old man. He has HIV for 33 years, and along with diabetes and hypertension. So when asked about engaging in ACP, what he answered is, I suppose if this question was put up maybe 14 years ago, when I first started, sure, but now, not that relevant, right? You are not worse off than the other person. You probably die from hypertension or diabetes before you die from HIV. So that's why the HIV medication is quite good. So when he said that, it means that he felt that SCP is not so relevant to him at this moment because of his condition, who is well controlled. And diabetes and hypertension is actually worse off than HIV. So secondly, looking at the second participant, who is a 59-year-old man, just recently diagnosed with HIV for 6 years without any comorbid. He said, no, I don't think about that because now that I'm on the medicine, everything is under control. It is like back to normal as usual. So if we look at this, in what happened in other countries, the norm now is HIV is a chronic disease. It's no longer perceived as a serious disease or a life-threatening disease. The same goes to Kenya, in which a study shows that your participants living with HIV believe that conditions such as arthritis, diabetes, hypertension, cancer, kidney, and liver diseases were more severe than HIV. In Canada, the people living with HIV actually prefer to live in the moment rather than worrying about the future. Some in the non-HIV population, they also have a similar thoughts as in HIV as in your condition now, as long as it's not life-threatening, ACP can be postponed, can be withheld. So this is a view, a perspective that as a healthcare provider, we need to take into account and consider so that we can explain to them what is the benefits, the pros, and discuss about having the ACP discussion now instead of when at the later stage of the disease where you lose the capacity, the decision-making capacity, when you are too ill to discuss about your values and goals. So secondly, we look on the views on death. So there are actually two views on death among all the participants. We look at the first one, who is a 52-year-old man having HIV for 27 years together with hepatitis C. He mentioned, if I died, I'd say to just dump my body into the drain. Just dump me into the drain. I think like that, no need all the fuss. So this participant actually has a from a lower socioeconomic background and is isolated from his family. So when he is isolated from his family and friends, he will feel that death is something that is not important, and hence ACP is not relevant to him at this moment. However, we'll need to explain to participants, to our patients also, that ACP is not only about death. Understand that, oh, this is how their views on death and the importance of including death into the discussion. So next, we look at another participant who is a 51-year-old living with HIV for 21 years and also hepatitis C. So what he said is, I don't want to be severely ill. It is better to be dead. I don't want to cause trouble to others. Don't want to trouble my siblings. I'm worried of prolonged illness, bedridden, unable to move around. In fact, I don't wish to be like that. It is better to be dead. I just heard about ACP now. So to him, death is a better off compared to prolonged suffering or a prolonged death. So because of this view, he is more drawn and keen towards engaging in ACP discussion. Another participant, a 60-year-old man who have HIV for 33 years, and also diabetes and hypertension. So what he mentioned is, I meant looking at the patient who is hooked up to the machine and is just taking up resources for nothing. The doctor suffers, the patient suffers, the family suffers. I think pretty much everyone suffers, is the way I look at it. So this 60-year-old man, to him, ACP is very important to him because of how he view prolonged suffering compared to dying at a comfort place according to his values and goals. So because of this view, he is keen to know and learn more about ACP. So now, when we discuss on these views on death, there are two categories of views. Some participants believe that death is uncontrollable, which led to a disinterest in ACP. However, some participants believe that ACP is very important because it is a platform to discuss about life-sustaining treatment, whether to forego future life support or not if their health deteriorates and becomes incurable when the prognosis is there is no prognosis is very poor. So it's important that we address these variations, these different views of death to enhance the engagement in ACP. And finally, the ACP delivery should be tailored. It should be a personalized discussion to address the views on death, whether indifference towards death or whether those who value death more than a fertile survival. So next, the third theme is about the fear of HIV disclosure. when the fear of HIV disclosure is present, it actually affects the uptake of ACP. So we have this 52-year-old lady who has a HIV for 19 years. What she mentioned is, I have told the previous doctor that I don't want to tell anyone about HIV. This is only between the doctor and me. Everyone is afraid of HIV. That's why I don't want to tell. ACP is important too. But sometimes people will know about it. If I join the program, they might say, look, that lady is there. I'm sure they are going to say that. So when the participants feel that, oh, ACP is related to HIV, and attending ACP means the person is living with HIV, there is this stigma on ACP, so it will makes a person less likely to engage in ACP. So when we look at another participant who is a man, 52 years old, he said, I will find a friend whom I can trust, a friend who can understand me. Or if I can't find someone, then I will tell the doctor. What I meant was I can't simply tell anyone about this because we are afraid that others may use it against us, look down on us, or they may spread to others about our status. So doctor becomes the surrogate decision maker, becomes the proxy when people living with HIV are unable to find a proxy. So this is the HIV-related stigma in which they worry that ACP carries a stigma specifically associated with HIV. And this fear of being associated with groups that are solely for HIV community is not only in Malaysia, but also in Canada, China, and United States. So we have to explain that ACP is for everyone, and it's not only for the community living with HIV. So stigma surrounding HIV and aging actually lead to social isolation. And hence we have to bear in mind that people living with HIV, they actually lack of confidante with whom they can discuss about ACP, about their preferred goals of care. Finally, the last theme is the desire to have a dedicated ACP service. When we look at this 51-year-old participant, he mentioned that it's easier to discuss our problem with one ACP doctor. There's no need to tell others. ACP doctor can represent us when the time comes with decision making. So to him, having one particular doctor, one particular ACP person is easier, whom he can talk about all his other condition, his current HIV illness, as well as other comorbidities, as well as his social and other problem lists, instead of multiple different doctors in different visits. However, some believe that planning ahead was fertile due to poor social circumstances. Because when we look at this participant, 58 years old, who have HIV for 17 years, he mentioned that when asked about proceeding with ACP discussion, he mentioned that would depend on financial ability. One would try his best to sustain his life if he can afford it. But for poor families, what to do? That's the reality. In this new era, you cannot survive without money. Money is not everything, but you cannot survive without money. So ACP service that is expensive, that is costly, can be something that is a negative point for people living with HIV to engage in ACP, or even for anyone from the non-HIV population. So this is a point that we need to consider as well. In terms of dedicated ACP service, it's very important that we tailor personalized ACP discussions to the individual's family dynamics as well as their socio-economic capacity. So studies from the Russia and United States also show that a strong social support could foster greater engagement in ACP as well as in healthcare. Inadequate support led older people living with HIV to depend on formal institutions such as hospitals or NGOs for their future care. This means that when they have no one to care for them at home, hospitals, formal institutions or NGOs becomes their only place to go when when they fall ill or conditions deteriorate. So, in conclusion, the state of health, their current state of health, we need to discuss with them in depth that ACP is not only for when their condition deteriorates. ACP can be started early and it can change according to your values and goals as time moves on. And it should be emphasized that confidentiality is the utmost important. So that ACP is not only for HIV community, but for everyone, and it is confidential. All the discussions remain confidential. Proxy appointment remains a challenge to older people living with HIV, and it should remain an important point of discussion. And doctors may be considered as one of the proxy or surrogate if older people living with HIV can't find a proxy. ACP framework, current national ACP guideline actually do not include the older people living with HIV. And in future guideline, it should include the older people living with HIV community because of the social circumstances and the challenges of a HIV-related stigma. A framework of ACP that is personalized, dedicated to the HIV community need to be developed from now onwards. With this, I conclude my presentation. Thank you.
Thank you very much, Dr. Alice, and congratulations for a lecture well delivered. Okay, there is a question from you, Gwen Chan. Not everyone is comfortable or good at advanced care planning for every chronic disease. Can we have a department of specialty look at this service? What is your opinion on this, Dr. Alice?
Thank you, Dr. Chan, for the question. I feel that, having a dedicated SCP unit or service is something that we should move forward to, progress to, in which we have healthcare providers who are trained in having SCP discussions. What I can give an example of what our neighboring country is doing. For example, Singapore. Singapore is dedicating SCP service to a private unit. Actually, the Ministry of Health dedicated it to a private unit in which they call it the AIC Center. I can't pull the full name right now. This center is a dedicated SCP service which they involve in the promotion of SCP in terms of social media, in the TV, as well as providing and facilitating SCP discussion with anyone, the community. But of course, having said that, all doctors should be equipped with the skills to engage in SCP discussion. I feel that there are a lot of literature that shows the barriers to engage in SCP, especially among healthcare providers. And one of the factors is the communication skills. Second factor would be the time factor. So when we look at the time factor, having a dedicated SCP unit could be a good point, so that doctors who are unable to engage in long SCP discussion can refer patient to the SCP unit, and the SCP unit will be able to discuss with patients about their current conditions, what are their future cares and goals. Yeah, and I hope I answered this question.
Thanks, Alice. Moving on to the next question from Reena Rajasuria. Her question is related to how persons living with HIV perceive death and the normalization of HIV. Did you manage to see any different views regarding how long the participants were living with HIV and this perception?
The perceptions of normalization of HIV. So I feel that most of my participants now, majority of the participants actually use HIV as normal, something chronic disease, because of their understanding of how the medication works, how antiretroviral therapy works, and the condition is controllable. They have a regular follow-ups. So majority of participants, I would say, view HIV as normal as diabetes or hypertension. Yeah. So in terms of views of death, it's not really related to how long they have the disease, but more to their personal belief as well as their experience, their past experience, whether their experience of being admitted to the ward. So and some participants who were admitted to the ward for example, for TB, one of the participants. So he mentioned about looking at others who are hooked up to machines, and that made him ponder on death. But participants who had a poor socio-economic background and no families or friends, they feel that to them, death is just nothing because nobody cares. Nobody will ask what I should just be, yeah, because nobody cares about me. So I don't care about death as well. So it's more towards their experiences, yeah, but not to the duration of HIV. Yeah.
Thank you for that. The next question is, does the ACP framework that you use include financial planning?
Um, Actually, the ACP framework, financial planning, I believe is living well. If you want to discuss, living well is a official documents which participants will need to discuss with their lawyers if it's available. In terms of us, ACP discussion, the framework, financials, I would say that is more towards how would they want to how would they want to how they want to plan. But in terms of the living will, the will, that one would need a lawyer, but we can assist them if they need financial help, as in referrals to NGO service, our social workers. That would also be included in the SCP framework, because it is something you cannot say, oh, I'll discuss this, I'll discuss that. No, it really depends on what the patient want to discuss and how it will affect their future care. And if financial affects their future care, yes, it should be discussed as well. So it's something very fluid depending on the person and values.
Okay, thank you.
Mm.
There's a question from Dr. Kor Hui Min. In comparison with ACP in everyone else and ACP, particularly in HIV individuals, do you think that it's more challenging to actually broach the subject of ACP due to the sensitivity of the diagnosis and the stigma, and that individuals only prefer to deal with only one person?
Mm. Actually, I do feel so, because when talking to my participants, I feel that HIV related stigma is still very strong here, if in the community, in even in their family members. So one of the participants I recall mentioned that he mentioned that my mother feel that TB is worse than HIV. But TB you can spread to other people when you are in the air. It's airborne. But HIV is not, as long as I do not engage in high-risk behavior. So the stigma is still very prevalent among the community, and the fear of disclosing HIV may make them fearing to engage in SCP, because they will feel that, oh, I talk about SCP, people may think that they will know that I have HIV. Then secondly, the fear that SCP is only for HIV people. So this is something that we should work on together as a healthcare team to make SCP for everybody. It's just like a healthcare screening is for everyone. It's not only for the HIV community, so that we can disperse this myth, or this misconception. Mm,
Okay, one final question, and that's from me.
mm,
Literature states that there are three categories of people for ACP: healthy individuals, that perhaps ACP is not so urgent. Then the middle category, where people have comorbidities, but it's not life-limiting illness, and the last category is people with life-limiting illness. Okay, in your opinion, which group does the people with HIV belong to?
mm. I think people with HIV belong to the second group, who have comorbidities, who have a chronic illness. So because from what I have done from my literature review, HIV population, even though the condition is controlled with antiretroviral therapy, the mortality rate is still lower. The risk of other comorbidities, neurological disease, heart disease is still higher. And they get these comorbidities at an earlier stage compared to non-HIV population. That's why I believe that ACP discussion should be started early on, so that when something misfortunes happens, we don't know, okay? And their values and goals have already been documented, and their dignity has been preserved according to what they prefer. Yeah.
Okay, thank you very much. And I think that's 1 more minute to 9 o'clock. I think we can end the session. Thank you very much, Dr. Alice, and for all the people that are in our audience today. And with that, I close the session. Thank you.
Paul. Thank you.